even good afternoon or evening, depending on where you're joining us from, given the different time zones. Welcome to the fourth and final installment of the Capitalize for Kids Virtual Café for 2020. We certainly recognize that you have many different ways to spend an hour of your day, and so we greatly appreciate you spending it with us and our guests for today's session. As 2020 has evolved, this virtual café has been designed to bring, frankly, our two worlds together. As you know, Capitalize for Kids works seamlessly with kids' mental health agencies across the country to find ways to increase capacity to support more kids and their families as they seek mental health support. During COVID-19, we, like many, frankly, if not perhaps most of you, have made significant changes to our business model to deal with the challenges created by this pandemic. With this said, the one thing we have been is unwavering in our support of our agencies, pulling back on change management and system implementations where required, and accelerating our impact where desired by our agency partners. Our focus during the period of substantial disruption has remained the same. We want to get more kids and their families the mental health help they need, when and where they need it. Throughout 2020, we've been working to get our implementations launched and engage with management teams to understand the impact we are having. Certainly a big shout out to our impact team, as we've had some great success in bringing opportunities to successful conclusions this year. We're definitely excited about building more capacity in 2021 and the prospects of engaging a myriad of different and new organizations, as well as starting new projects with very familiar and well-established relationships. By engaging through the virtual cafe, we've created an opportunity to explore the two worlds we abut, the healthcare community and kids' mental health in particular, where we deliver our consulting capabilities, and the finance and capital markets community, who generally financially support our organization. We're absolutely delighted to host two leaders in these respective verticals, Ron Haik, Senior Financial Advisor, Nicola Wealth, and Dr. Daphne Korczak of the Hospital for Sick Children. Ron is a Senior Financial Advisor and the Regional Manager at Nicola Wealth's Toronto office, with over 20 years of experience in the financial services industry. He has gained a breadth of knowledge working with some of the world's largest financial institutions, advising clients in a variety of roles, such as financial planner and investment advisor, in the areas of domestic and offshore planning for the high net worth segment. He is a seasoned lecturer at industry and association conferences, seminars, and post-secondary schools across Canada, as well as a subject matter expert on investments and planning for incorporated professionals. Ron holds an MBA with a double major in finance and financial services from the Schulich School of Business. Dr. Daphne Korczak is the director of the Children's Integrated Mood and Body Depression Program, a child and adolescent psychiatrist, associate scientist at the Sick Kids Research Institute, and an associate professor in the Department of Psychiatry at the University of Toronto. Her research focuses on the relationship between early onset depression and future cardiometabolic risk, and on youth suicide prevention interventions. Dr. Korczak is also the chair of Mental Health Task Force of the Canadian Pediatric Society. We are particularly proud of the work that has been done by Daphne as Sick Kids is a founding beneficiary of our organization going back to 2014 through the Kids Brain and Mental Health Research Program. We have been financially supporting Dr. Korczak's research into suicide prevention for youth, which remains a leading cause of death for our youth. So over the next 45 minutes, we'll have two of our speakers talk about the economy, markets, advancing mental health, and the prevention of suicide. And we'll have Ron speak about the work being done at Nicola Wealth, the evolving markets, and some implications of COVID-19. Then transition to Daphne to focus on the kids' mental health experience inside the hospital setting, and particularly the experience in emergency departments as it pertains to suicide prevention. Following their talks, I'll host a Q&A with the panelists. I'll certainly remind the panel. Of course, like all of our events, we'll aim to get you out of here on time. Now, I would normally ask everyone to give Ron a warm welcome with big time applause. I can hear the clapping virtually, and I'll turn the mic over to him. Ron?
Thank you so much for the invitation and for that introduction. I really appreciate being here with all of you today, and I think our focus today will be in the next 15 minutes to look at pandemics and the portfolios and touch upon some of the mental health aspects too, I think, which is quite important. We're certainly seeing an impact of that as well from our perspective. So the agenda will follow as follows. We'll talk about the markets briefly. We'll look at the current COVID crisis and its impact on the economy, what that means in terms of our emotional behavior and what we can do about it through some effective planning. And we'll touch upon philanthropy as well, because I think it's really an important part today more than ever. So let's talk a little bit about the markets. And if you start to read the news, the stock market's crazy expensive according to the Wall Street Journal, but they're okay with that. And, they feel that there's nothing wrong with the market being expensive. But if you look at David Rosenberg and his opinion, historic proportions, the bubble, and the question is who's right and what can we do about this, if anything, or should we be doing anything about this? So let's look at the markets. This is until last Friday's close. The NASDAQ was up nearly 60%, the S&P 500 nearly 30%, and the Dow Jones was up nearly 17%. Now that's not from the bottom of March 23rd. The NASDAQ is up, in fact, almost 80% from March 23rd. So when you look at this, you think, wow, this is amazing. Markets are fantastic. But what we really have is a bifurcated market where we have some poor cousins in here. When you start to look at the broader markets, the broader indices, like the New York Stock Exchange, the Toronto Stock Exchange, London is down to nearly 13% still, as is China's Hang Seng and Euro. So are the markets really reflective of the economy? It's often said the markets lead the economy, but we certainly believe the markets and the economy do not move in lockstep. So let's look at the economy a little bit. When we start to look at the markets, and we talk about the S&P 500 being very expensive, we're going to look at the S&P forward earnings. So this is a chart until last Friday's close, and what you see is that we're at a level from a price to earnings ratio that exceeds that of the 1929 stock market crash and the 2008 financial crash. The only other time we've been higher than this level is the dot-com. And when we start to look at COVID and what it did to our economy, I'm going to show you a busy chart, and I apologize in advance, but the blue shows the economy in different sectors of the economy. And you can see that sometime around March, all the brown, the orange, that's where those sectors start to slow down. And specifically, when it ended up happening is that most things got worse. This is a chart to the end of August, except for financial markets. The only other sector that was doing well during this time was actually mortgage refinancing, owing to lower rates and people being stressed in terms of financial. So when we look at this and look at Canada specific and where we are in terms of recovery, you can see the Canada Recovery Tracker, which is a measurement out of Oxford Economics, peaked in September 2020, and we're actually having seen a degradation of that. And what you'll see is that they recently published that the Recovery Tracker has had its sharpest drop since April. So is the market perhaps really looking forward to good news? And what might be that good news that it's expecting? And not surprisingly, whether it's the Pfizer vaccine or the AstraZeneca or the Russian Sputnik vaccine, and China announced one this morning with an 86% efficacy, it certainly bodes well. The question is, will the public trust the COVID-19 vaccine rollout? And when we start to look at different countries and how does Canada fare relative to others, if a vaccine were available, there's 2 points in times here. One is in August and one is recently in October, and Canadians are consistent, if anything. So you can see we're unchanged, and unlike many parts of the world that have seen a pullback, less buying into it. So One issue though, so when we look at this vaccine and people adopting this, and we look at markets, one of the issues though is what has kept these markets going, and part of it is massive stimulus. We're giving, paychecks out, we're giving CERB, and we should be doing this sort of thing. But one of the questions we often ask is, who's going to prop up this deficit? How are governments going to pay for this debt that is nearly $400 billion? So let's look at this from a historical perspective. This is a chart from the Fraser Institute, and it was done for Canada's 150th sesquicentennial anniversary to 2017. And it looks at the type of debt we've had and the interest payments or deficit support, if you will. In World War I, it was at 40%. 40% of our public debt charges represented the payments. It reduced to 20% in World War II, and it got worse during our debt crisis, up to 30%. And in 2017, that number was 7%. And today, with lower interest rates, that number is less than 7%. So typically, we never pay down our debts. We actually grow our way out of it as the economy continues to grow. So when we think about this, we think about, okay, lots of things we can't control. We can't control whether COVID vaccines come out, their efficacy, and so forth. You can only control your response to things. And so when we start thinking about this from an individual investor behavior or an individual behavior, we can't let our current world affect our mental health. So when it comes to investing, this is a simple graphic. A typical emotional investor starts off, they're brilliant, markets are going up, everything is fantastic. And then as you start to see a market sell off, you start to question, and there's going to be some fear, some desperation, maybe some anxiety, and then there's capitulation typically. And this is, the March 23rd, the bottom, where you're getting out, you can't handle it. There may be some signs of depression afterwards. Why did I get in? I lost that. So when it comes to investing, your behavior is a very, very large part of your returns. And there's a couple of great books on this that I would encourage anybody to read on. And let's actually put in perspective what that effect is on your returns. So when we look at the impact of emotion in investing, we look at investor performance relative to the S&P 500, and then the difference between them, which is the performance lag. And that you can see that number is typically a 4 to 5% annual loss of return. Investors typically underperform. So what's the one thing that we can do, all of us, to mitigate the stress we feel? And I would say one of the things we can do is engage experts to help us along the way, whether it's mental health practitioners or advisors to help you plan. So we gather that information. It doesn't matter what income tax bracket you're in. There are still income splitting opportunities despite the tax on split income federal rules that came out in 2017. One of those ways is to donate. And we'll spend a bit of time on that. Maybe the use of flow-through shares. If you're an incorporated professional, there's certainly advanced tax planning that can be used. And non-traditional portfolio design can also help mitigate the effects of taxes. So let's focus on one thing in particular right now. And that is you have to have a customized approach based on your situation. There is no one way of doing it. Here at Nicola, when you're sitting with your advisor, you're looking at working with them, their accountants, you're moving beyond stocks and bonds. That's the non-traditional approach that we talked about in terms of portfolio design, tax reduction strategies, whatever it might be, succession planning. A big part of what we believe in is charitable giving and the goals around that. And at this time today, for organizations such as this one, Capitalize for Kids, there's never been a more important time to donate. The donations are far more impactful today. So let's look at donations. And basically, there's three ways one can donate. One is at the door. That's to family and friends. There's a bike-a-thon. They're running a race of some kind. One is planned giving. We'll look a little bit about that. And then what we call at Nicola strategic philanthropy, if you will. So when we talk about planned giving, it's important to look at the different tax rates. So in Ontario, if you're fully taxed on your RSPs, your pensions, on your capital gains, on your shares and so forth, corporate holdings. So there's a real tax grind to what's left behind. And of course, there's probate. So when you think about your beneficiaries, there's really three possible beneficiaries to your assets in your estate. And if I said to all of you on this call, pick two, I don't think any of us would be picking the government. That's typically not what we want to do. And there was an old saying that reflected this by Morgan Stanley down in the US, and they said, you've got to pay your taxes, but there's no law that says you got to leave a tip behind. So with good planning, you can get control of your emotions, you can get an understanding of where you're going, and you can benefit those who need it most. And so let's look at some of those gifting options. Whether it's through a will bequest, your RSP donation, appreciated marketable securities, or gifts of life insurance, those are all gifting options. And those are very transactional, I would say. They would happen at a time that something would happen. What we would ask you to think about is incorporating philanthropy discussion at every meeting with your advisor. This is what we would call strategic philanthropy. Think about this from our perspective. This is something we do firm-wide, and the reason we set up for our clients a charitable foundation to encourage them to give. So we have set up a private giving foundation. It is a registered charity. It accepts donations of all kinds, makes grants to other Canadian registered charities, and strategically maximize your tax benefit in any given year. And so what's important about that is you can grow your legacy, make the donations during the lean years, but continue to give in perpetuity. And that's really important. It is a lean year, and we would encourage people. As a firm, we're committed to leading by example, which is why we donate almost $1 million corporately to various organizations. And in addition, we have a charity committee that matches staff donations. Staff are very philanthropic minded as well. Our donor advised foundations, donations can be made in cash or in kind. Under certain circumstances, even private company shares can be donated. And there is no administrative cost. This is part of Nicola Giving Back. We bear the cost of those administrative services to the private giving foundation. So let's just summarize quickly where we are. We talked about markets. Yes, they are expensive. We talked about a disconnect, if you will, between the current crisis and the economy. And what can we do when it impacts our emotions? And one is to note them. Yeah, they're there. How can we control them? That's through judicious planning, and it's customized to you. And we certainly hope that you would consider philanthropy as a strategic part of your planning. So with that, I thank you for your time, and I'm going to turn this back over to Quentin. Thank you very much.
Marvelous. Thanks, Ron. Greatly appreciate those insights into not only the markets, and we'll probably circle back with you on where you think they're truly going for those opportunities in front of us, but also the focus on philanthropy, obviously near and dear to our heart, and we appreciate Nicola's support. Now I'd like to ask you to put your hands together and create a warm virtual welcome for our next speaker, Dr. Daphne Korczak. Over to you, Daphne. And you're on mute.
Thank you. Thank you, Quentin and Ron, and thank you for the opportunity to speak today. Speak a little bit about our work and more broadly, youth suicide prevention and what we know and where we think we need to go. So I have some research support. I have no conflicts of interest to disclose. As Quentin mentioned, initially, suicide is the second leading cause of death in Canadian children, and to put that in perspective, more children take their own lives than the top 10 leading causes of death by medical conditions put together. And so it's quite a concerning situation in Canada, also around the world, which we'll talk about briefly. And the precedence to this is really thinking about suicide, which is also concerningly very common. And whether it's Canada or the US, about 1 in 5 high school students will report seriously considering attempting suicide, and about 15% will say that they have had a plan for how they would attempt suicide. Despite the efforts, despite research, primary prevention highlighting the issue, we see a concerning increase, about 20 to 30% increase over the last 10 years or so in suicide rates among youth. Now, this is US data, but if we look globally, we'll see the same thing. And this is sort of a global survey of suicide rates. Canada wasn't originally in this survey, so it sort of snuck us in there, roughly where we go. And you can see that we're right up next to the US with respect to our suicide rates, and very much middle of the pack around the world. And because of this, it is a global problem, and countries increasingly have recognized that there's a need for a national approach. And this is a smattering of some of the countries who have developed a national suicide prevention strategy. Canada is not on that list, and in fact, although not all the G8 countries are listed, Canada is the only G8 country without a national suicide prevention strategy. And that's a point that has not been lost on the world. So this is a paper that was published a couple of years ago in The Lancet in the World Reports, a prestigious medical journal, very high impact factor, very well read, highlighting in their editorial Canada's lack of a national suicide prevention strategy, one of the few industrialized countries without one. And so if we think about developing such a strategy, though, well, we need to understand what might work with respect to suicide prevention. Where do you start when you tackle this kind of a problem? And usually when we think about those kinds of questions, we start with, well, what do we know? What do we know so far? And so I'm going to tell you a little bit about the emergency department and what we know about the emergency department and its potential role in youth suicide prevention. And I think it'll become clear why in just a minute. So around 2015, Ron Finkelstein in our group led a study looking at adolescents who come to the emergency department, any Ontario emergency department, with a first overdose ingestion, and looked at about 20,000 adolescents, and then matched them, age and sex matched them 50 to 1. So looking at about 1 million healthy controls, adolescents who didn't come to the emergency department with an overdose ingestion, and then followed them over time, and found a couple of things. First, found that more than 99% of the kids who came to the emergency department with the first ever overdose ingestion, intentional overdose, survived to discharge. Also found that if you followed these kids out over time, probably not that surprising that a year after their index visit, there was a higher rate of death by suicide in the group that presented. What was more surprising was that 10 years out, there was still 10 times increased risk in that group compared to healthy adolescents, and really showing us that in that adolescent period, coming to the emergency department with a first ever suicide attempt provides us with a very important window of opportunity for secondary suicide prevention. At around the same time, Kathy Bennett at McMaster, also with some members from our group, conducted a review of the worldwide literature, looking at effective youth suicide prevention interventions, or rather looking at all suicide prevention interventions for youth and trying to understand signals for effectiveness, and looking for themes, looking across school-based interventions, primary care interventions, emergency department, and other community interventions, and came to the conclusion that emergency department transition and these kinds of programs are the ones that may reduce suicide deaths, hospitalizations, and treatment, coming to the same conclusion, although working independently from Ron and his team, showing that, emergency departments really have a lot of potential for an effective suicide prevention program for children and youth. And so we think from that, here is one area where we could inform a component of a national suicide prevention program. So, okay, so the emergency department seems like a promising place to intervene. But then, of course, the question is, well, what would you do in the emergency department? What kind of intervention would work? And I'm just going to give you here like a very bird's eye whirlwind view of what we know about interventions based out of the emergency department. So the first idea was, you know what, people come to the emergency department, what they need is they need some education, they need some interaction with a therapist in the emergency department, hook them up with community services. And once we have them hooked up with the community, then we can see that they'll understand that they need to follow up there, and that will be their support. They won't come back to the emergency department. And if you do this, as a couple of studies have done, these are randomized controlled trials, one-time assessments or one-time interventions, you can see that you can increase the adherence to aftercare or following up in the community, but it doesn't affect suicidality, so suicidal ideation or suicide risk behavior. So then the thought was, okay, well, perhaps what they need is other coping strategies, other problem-solving behavior, safety skills, because if they had those, then they wouldn't resort to suicidality or suicide attempts, and they wouldn't present to the emergency department with that level of distress. And so this has been tried in a few different trials, group-based, individuals, and again, unfortunately, all negative trials. So what about asking youth, right? This youth know what they need. We'll ask youth what they think would be helpful for them. This is one of several trials led by Cheryl King in the US, asking youth to nominate supportive people in their lives, whether it's peers or adults, and thinking, you know what, if we just increase the number of contacts that youth have with supportive people in their lives, then they will be able to contact one of these many folks, and when they're distressed or when they're feeling suicidal, they'll be able to reach out rather than feel alone and come to the emergency department. And when she tried this in a large randomized controlled trial, found that yes, you could increase the amount of contacts that youth had with those folks, but it didn't impact their suicidality. Now here's where we start to see a signal. What if we involve parents and families? And we start to see that if we involve parents and families in those interventions, now we can start to see an impact on suicidal ideation. We can see an impact on suicide risk behaviors. Some of these interventions, though, were fairly lengthy, 10, 20 sessions. It's quite a big commitment for youth and families. And in fact, just to show you this out of interest, if we only involve families, this is an interesting small little study, but it's so interesting I wanted to include it. We don't actually involve the youth at all. We just involve parents in treatment. We can impact the youth's suicidality. So it was very interesting. And more recently, a large study looking at something called dialectical behavior therapy, which actually included a very large parent-family component, again showing that if you involve youth and if you involve parents and family in an emotion-focused regulation intervention, you can impact suicide attempts. And so from this, what do we glean? We really glean that to be effective, an intervention has to be family-focused and it has to be of sufficient duration to impact suicidality. So this has really been consistent with what we have recently found in our study of near-fatal suicide attempts. This is a survey done that was in partnership with the Canadian Pediatric Surveillance Program as well as Public Health Agency of Canada among Canadian adolescents who've made a serious suicide attempt that have required intensive care unit admission. And looking at that group of adolescents, looking at what preceded or precipitated the suicide attempt, we see that by far and away the most common precipitant for those attempts were family conflict. And the numbers 2 and 3 on that list are actually quite a bit lower in proportion, around 20%, and they're sort of tied for second. But even though family conflict is by far and away the most common precipitant of a near-fatal suicide attempt, 2 out of 3 parents actually didn't have any idea that their child was even considering suicide. And there they were in an intensive care unit, really very shocked. So these data are also consistent, and the literature findings also consistent with our clinical experience. And this is what led to the development of our own family-focused intervention at Sick Kids. And With support from Capitalized for Kids, as Quentin mentioned, we were able to conduct a pilot randomized control trial in our emergency department. So this is an intervention that's a standardized, manualized intervention. It's weekly treatment for 6 weeks following the emergency department presentation, really addressing the most common thoughts, feelings, and behaviors that suicidal youth and families experience. It targets suicidality directly, and it targets our hypothesized moderator in our mechanism of action, addressing family conflict and communication in the association between an at-risk or high-risk adolescent and a suicide attempt. For anyone interested in the specific details of this trial, you're welcome to have a look at the protocol, which is published earlier this year. But this trial has been really instrumental for us in learning how to conduct a pilot of a trial such as this, because as you can imagine, it's not the easiest thing to do. It's a challenging population. There are issues around randomizing adolescents to an intervention or to a control condition, and learning how to make it feasible and acceptable to patients and families so that we are able to test its effectiveness. And happy to be able to share that the next steps for this line of research is to do just that, and to test it in a larger sample in multiple sites in order to determine, is this scalable? Is this something that we can export to other centers? And will it be acceptable at those centers? Is it effective? So now we can have a large enough sample size across both academic children's hospitals as well as community hospital and test its effectiveness as an intervention. And if it is, then can it inform one piece of a national youth suicide prevention strategy that will be meaningful and evidence-based? So this trial so far has been funded by the Canadian Institute of Health Research, CIHR, and the Canadian Children's Hospital Foundation Network. And we're just about to launch it this winter. So pretty excited about that. So I just, before I wrap up, like to acknowledge our co-investigators, the collaborators, some of our trainees and our team, all of the kids, families, and funders. And thank you. At this point, I'll just hand it back over to you, Quentin. Thanks very much for your time.
Thanks, Daphne. Certainly, as a dad of 3 kids, we greatly appreciate, as a family and as an organization, the work that you guys have been doing. We're very proud of the support that we've been able to provide to sick kids. As a parent, as you stand back and look at that first set of data that you provided, it's chilling to contemplate just how impactful suicide is. So thank you. Now that and I'll try and hold it together. Now that the presentations are concluded, I'll remind all of you in the audience that you can access the question box. And I think we've already had some come through on the screen, and you'll send it through to Sarah Beeson, who will collate the questions for the panel. While that's happening, I'll start the Q&A with a couple of questions and see where we go from there. One of the ones that I'm very interested in, and Ron, it basically plays off of that very interesting graph, what I would think about as a roller coaster graph of emotional investor. And I'd also think about that in the context, Daphne, of your work and the implications for kids' mental health, and how that drives or doesn't drive towards suicide ideation. So if you think about the emotional experience in both realms, Ron, kind of the influences to the investment portfolios and the way forward, the highs and lows, how do you make sure, because things can get really high, things can get really low, that you create the right place for yourself as a family or as an investor? And then Daphne, similarly, you know, those highs and lows, I would say, again, as a dad, if I think about information, and probably this reflects to you too, Ron, the bombardment of information. In the case of kids, social media, the readily accessible flow of information, you never seem to be able to turn it off. In my old days, when you went home, you were free of it. Now it's still there. So it creates that emotional roller coaster. So I'd love if both of you can talk in your respective regimes and see where we get to. So Ron, I'll start it with you, and then we'll migrate to Daphne.
Thanks, Quentin, for that question. As you asked that, I was starting to think, what's the most important thing? What's the one key issue that we need to deal with to manage our emotions? And that is to talk through things, to have a dialogue, whether that be with our spouse, might be with our kids, it might be with friends, it might be with experts like myself on the financial side, or Daphne and her colleagues. Financial health is so intricately tied into mental health. You know, when business is good and your financial life is strong and you're not worried about, you know, where your next paycheck is coming from, you have the ability to focus on other things, raising your kids, raising your family, you know, being there for them. But if you are thinking about, oh my God, where's the next paycheck? How am I going to make the mortgage payment? I want you to step back, guys, and think about all those workers who have lost their jobs in this pandemic. We're blessed that, you know, we're in an organization that is essential. I continue to work, but my heart goes out to those who are not working and have those concerns, that next paycheck. So whether it's during a pandemic, you know, and next year, before, after a pandemic, and any time, it's important to dialogue about these things and to talk. And that dialogue leads to good questions. It leads to good information, and then leads to planning. Okay, here's what I can control. I can't control whether, you know, Doug Ford or any other federal or provincial official shuts down my office or my business, but I can't control how I'm going to prepare for that in advance by ensuring that there's proper planning in place from a financial perspective. So it is managing those emotions comes with gathering information, reaching out to advisors, and putting a plan in place to manage unforeseen scenarios. And when we are working with our clients, certainly, and I know many advisors do this, it's about scenario analysis. What happens if I am unemployed for 3 months or 6 months? What's my plan? What happens if the markets, correct from here and stay down for a progressive amount of time? What am I going to do? So, and I think in many ways that probably would mirror, the mental health side of things, talking through things. But I'll pass it over to Daphne. That's her area of expertise.
Thanks, Ron. Daph? Yeah, you're good.
Am I good? Okay.
Yeah.
Thanks, Ron. Yeah, it's interesting that how many parallels there really are, and I think that is very true when I think about social media and its impact on adolescents and its impact on families. We used to joke, is everyone going to carry around these cell phones like an accessory lung? And certainly, actually, yes, they do. And so it is really challenging, and we are learning how to use social media, I think, over time. I think we do it better than we did sort of 10 years ago, certainly 5 years ago. But we are still learning about how to use it responsibly, how to teach kids about how to use it, and the education around it. And that's really quite key. Is I think what we have seen is it's really important to teach children and adolescents as they begin to use it and as they have different experiences with it. It's very similar to what Ron was saying about, what is our response to that going to be, and what is the place for that, and how do we critically evaluate what comes through? Is this supportive to me? Is it hurtful to me? We have to teach kids and adolescents sometimes what is a friend. Friend gets used in so many ways in social media. but what is a friend and what is a real friend? And how do you know who your friends are? And then looking at that, having those conversations within a family sometimes can be very important, not just within the family, sometimes also within the school. We find that it's really important to help kids learn to unplug and have those times. And sometimes the easiest way to do that is actually not to enforce tech-free times, although that certainly is one strategy, but to really grow alternative activities. And so whether it's sports activities or other clubs or activities, other non-social media-based activities, it's been very challenging during COVID. And hopefully that will be something that comes to an end at some point in the not too distant future. But generally, the way to address it is to grow the competing activities, because by and large, kids will always gravitate towards in-person activities where they're supportive and fun, and then helping to talk with kids and families about how do we respond to negative feedback, and what is important to listen to and what isn't. But it definitely a lot of similarities to what you were saying, Ron, about emotional responses in general. It's a great question.
Thanks, Daphne. You know, if you think about some of the work you're doing, and then you highlighted, I think, 4 different organizations. You'd included Trillium, McMaster, I think Calgary, and I can't remember if the other one was Sick Kids. But if you think about learning from the mistakes of others, in your world, the stakes are just too high. So how do you think about building out a better system of support, given we've got a provincial delivery of healthcare providers, you've got community-based that really are mostly on the ground. I mean, an ED is kind of the last resort. So how do you think about that as a more national-based prevention strategy? Is it within our fingertips? Is it so far away that like it's better to just keep doing the ground strokes in the individual organizations? What are your thoughts there?
I mean, that's a huge question. It's a great question. And, could be the king of Canada if I had the answer. I think that one of the things that certainly the medical and the health community does quite well is adopt things that work. And so one of the challenges that we have always had in children's mental health is that, the pressure, the sense that we need to do something has sometimes been so great that, as you can see, that the time, the due diligence, the effort that's required to actually take an intervention and test it, especially if it's a non-pharmacological intervention like a therapy, it's quite labor intensive and it takes a lot of time. And sometimes in that pressure to what we have to do something, we've adopted, not just in Canada, but all over the world, we've adopted treatments that seem like they ought to work, or that sound like they should, or that someone has tried with somebody or a group of kids and it seems to have worked, and just have adopted that, implemented it in their setting. And as a result, we end up with sort of a patchwork of interventions all over the place. And you can even see that in Ontario very clearly. If we have a child who's been admitted 3 times for suicidality, they will have received 3 different types of approaches. Same is not true if you have a child with asthma who goes to the emergency department with an asthma exacerbation. Their treatment, regardless of where they go, is pretty similar and standardized. And that's because those asthma treatment trials have been conducted and it's been quite clear what works, and we should do what works. So I think that, for a national suicide prevention strategy to really get some uptake, it has to be grounded in what works. And if we are able to do, we're working in the emergency department, others are working in primary interventions, we're able to gather the evidence regarding what works and develop interventions that don't rely on, a certain therapist's skill set or a certain therapist's fit with the family, but actually are standardized, are manualized, are able to be disseminated and scaled, I think we'll find that actually the uptake of those, the appetite for those is quite large. And it will be much easier to disseminate those kinds of treatments quickly across other settings. I don't think it's for a lack of interest that people are in these various sort of patchwork systems. It really is just a lack of evidence base. And so that's really what we're working to try and forward. Thanks,
Daphne. I mean, Ron, I mean, in a kind of similar parallel world, I mean, the investment community typically learns pretty quickly. If something works, they glom onto it. If it doesn't, they discard it and drive on to the next one. Kind of that same question, learning from the mistakes of others. When you look back historically in periods of time, you looked at debt requirement or debt levels, but there's also a myriad of different, market crashes, market upsides. What do you think for 2021 that we should be learning as we go into this next year to enhance and help us from an investment perspective?
So when you ask that kind of question, it's interesting because we're talking about history and what can we learn from history. And I think what we in the financial services industry continue to learn from history is to continue to evolve and not be content with what has happened. Any investment will have a standard disclaimer of it, right? Past returns are not indicative of future performance. And as an opportunity arises, if the marketplace finds that it is a good opportunity, it becomes crowded, and the value adds disappears over time. We think that in 2021 and beyond, the move to private assets is going to be very important for investors. Traditionally, a 60-40 bond portfolio, publicly traded bonds and stocks, or stock portfolio, was supposed to have provided the kind of returns to sustain you. And it might only if you don't have emotion involved. And I would say that for 98% of clients, they are emotive. Advisors are too. We're human beings as well. So as you move to a more private type of portfolio, and what I mean by that are things like private debt, private equity, private mortgages, private hard asset real estate. If you can get those kinds of private assets in your portfolio, they produce cash flows. There's consistency, there's stability, that you're less likely to be emotive and reactive, either as an advisor or as an investor, to market swings, because you're not relying on the stock market. And while the stock market and the bond market traditionally did not move in lockstep, we're seeing that the two of them are moving. Back in March, we saw both of them, go south. And so stock market was down 35%, whereas the private assets, their values held very strong. So in 2021 and beyond, a move to what we'll call non-traditional portfolio design, we think is key to continue to preserve and grow your wealth.
And just, and I don't know if you want to touch on specific names, but obviously in opportunities like this, there's a lot of baby going out with the bathwater. So, cruise lines, airlines, blah, blah, blah. When you think of pharma, and this is actually a question from our watchers, is that an opportunity? Or do you think, look, vaccines are in such a place where they're not going to have price control? It's going to be dictated, and therefore, while it'll be interesting, it really won't be opportunistic.
So the old market saying is buy on rumor, sell on news, and we know the news is out there. We've got at least 3, possibly now 4, with the Chinese announcement today of vaccines. So what's happened is we've had a rush to market of a product, and the market is going to get saturated. Again, if you're looking at price appreciation, whether it's pharma, whether it's retail, if you're looking at price appreciation to drive your returns and your financial security, you're going to ride that emotional roller coaster. If you can instead find an investment that pays you consistent cash flow, you're a little more even keel, and you're able to make less emotive decisions. You're not relying solely on price appreciation. So pharma might very well be the right solution if you've got cash flow to sustain it and you're not worried about price appreciation, and if it's a sustainable cash flow for that business.
Thanks, Ron. Daphne, there's a lot of questions coming in around schools and the role of the school. And I guess there's probably, the role of the family, the role of the school, the role of the healthcare system, and each touch our children in many different ways, but the family and the school system obviously front and center. How do you think about the engagement with schools, school boards broadly, to the solution for, if there is such a thing, for suicide ideation?
Yeah, schools are important, and it's a good question because they are important, and they've been very difficult in terms of environments. And so just for reference, what we've been talking about in emergency departments are something called secondary prevention. This is prevention of suicide among children who have already presented as someone at risk of suicide in that they have made a suicide attempt. It's the greatest risk factor for death by suicide, is having a prior suicide attempt. And so that is why our focus has been in sort of the secondary prevention. When you look at schools, we're really looking at primary prevention. And so there are obviously kids who have been thinking about suicide in schools. There are kids who have made suicide attempts within schools, but there are also a lot of kids who have not either thought about suicide or made suicide attempts. And so the prevention effort that needs to be made at the school level is somewhat different. I can only say that so far there have been several primary prevention interventions that have been tested in school systems, in the US primarily, but also in other countries. And so far the results have not been so promising. In general, they've been negative trials, probably because they're getting mixed results depending on the age of kids, depending on the gender of kids. And we actually see some differences if we look at gender here. It's interesting, in a few trials, school-based trials, what they have found is if they look at effects by gender, they see that some of the interventions have been helpful for girls. Girls will say, actually, yeah, I learned something, and I think that was useful, and maybe I will speak to a friend or a guidance counselor or someone if I have these feelings. What's been concerning is that it's not had that effect on boys. And again, this is just a couple of trials. It's certainly not exhaustive. We haven't hit the right note with school-based interventions yet. But in a couple of trials, boys have actually had not just a neutral response, but a negative response. And we worry about potential harm a little bit in boys who nothing. I don't think I'm less likely to talk to someone, and that is very concerning, because there's a gender paradox in suicide and youth suicide, where girls make more suicide attempts, but many more boys die of suicide. And so we worry a little bit about when we start to see gender-based findings like that. It just tells us that although schools are possibly and probably an important place to include within primary intervention efforts, we haven't quite figured out the right way of doing that yet.
When we did some initial work with Trillium Health Partners on Project Zero, and Project Zero, for those of you trying to drive towards a zero suicide rate for youth. And their focus there was a community-based solution. So yes, the hospital, the ED, the justice, public, private, Catholic schools, community, Peel Children's, and now Every Mind. Everyone together supporting the family and the child. The same, I think, Ron, when you think about, trying to create wealth and ultimately wealth to philanthropy, bringing together everyone to focus. So in both cases, Daphne, when you look at that, is that, well, the work you're doing really looks at what the ED can deliver in support. Is that the necessary end, really, is a full-on integrated community delivery to be able to get true measured success, which would be, I think, 0 for all of us? That would be the ideal number. And then Ron, similarly, when you look at ultimately driving towards the health of your client, that it really is a full-on review from top to bottom, insurance through to investing and philanthropy, etc. So sorry, that's a long-winded question that I've only got 4 minutes to have two answers. So Daphne.
Okay, I'll do the quick answer, which is, yeah, of course. I mean, in general, things work better when everyone works together. That's always true. I think that the key, though, is that in each of those settings, what is it that people are doing? And that school-based piece, that community-based piece, that emerge-based piece, yes, definitely everyone, I don't think anyone would argue that it will work a lot better if we work together. The bigger question, I think, if you're at the sharp end, is to say, okay, but then what is it that I'm doing once that kid comes to me? What is it that I'm doing in the emerge? What is it that I'm doing? What am I delivering in the school? What does that working together look like? And that's where we've been trying to advocate strongly that just like in every other medical condition, we need to treat kids with interventions that work. And we need to show, like, they deserve interventions that have been shown to work. And so, and that's why we have focused in one area, but it's similarly, we need to work with every other sector. Absolutely. We also just need to make sure that what everyone's doing is actually an evidence-based strategy that works. Yeah.
Thank you, Ron.
I would echo that there's a lot of parallels between the mental health area and the financial health area. And part of what I'm hearing with Daphne is that really no person's an island onto themselves. It really takes a team of specialists. So there are a lot of great general practitioners out there, but when it comes to mental health, financial health, you need a team of specialists around you. And more importantly, or as importantly, you need someone to coordinate that. So I suspect, my wife's in a mental health field as well. There's a case coordinator a lot of times who is ensuring, as Daphne said, people in the hospitals, people at schools, people at home are supporting that scenario. It's the same in the financial services industry, or it should be. Your advisor, the one you're working with, should be that specialist, that coordinator who understands where your lawyer comes in, where your accountant comes in, where tax planning comes in, and brings it all together and creates a customized plan to your benefit, your objectives, your family's goals. And part of that isn't just financial or math or tax. It is about managing the emotional piece of it by providing the dialogue, by ensuring that we're constantly connected with them and saying, you're going to be okay. Or if this happens, here's the plans we put in place to mitigate any negative effects. And so it's about having that specialist working collaboratively with all your advisors.
Thank you, Ron. Thank you, Daphne. Extraordinary. It's been great talking with you guys this morning. It's just now going to chime over to 12 noon. We pride ourselves in getting people back to what they were previously doing. To everyone who's joined us for the Capitalize for Kids virtual cafe, thank you very much for spending your time with us. If you want to support Capitalize for Kids, you can certainly do so at www.capitalizeforkids.com. We'd love to see you in the future, whether it be at the Bay Street Games, at our investor conference, or at these virtual cafes where we have great lineups of speakers. And of course, our podcast, which we just released. Deborah Gillis, who is the president and CEO of CAMH Foundation, Michael Landsberg, Sick Not Weak, who's a wonderful ex-TSN personality, and we'll have more of those to come also. So again, thanks. Hope you enjoy the rest of your day. Ron, Daphne, wonderful to have you along with us today. Thanks very much for your time. Take care, everyone.
Thank you. Stay safe, everyone. Happy holidays.
Thank you. Thanks, Lynn.
Thank you.
Appreciate it. Bye now.
Bye-bye.
Bye-bye.